afternoon. My topic is phaco in Fuchs endothelial dystrophy. Uh, so it's actually on grade stage 2 endothelial dystrophy, but
Into your mic because they're recording the session.
yeah. So we all know Fuchs endothelial dystrophy is like an autosomal dominant type of dystrophy. It's a non-inflammatory condition, and before going further, we should know what are the stages of Fuchs dystrophy. Stage one is actually American Academy of Ophthalmology staging, and stage 1 to stage 4. Stage 1 is actually you see a few central guttae, and the patient is not symptomatic. Visual acuity is 6/6. If there is a cataract, of course, it can affect the vision, but otherwise, the corneal condition will not affect the vision, and the patient is not symptomatic. Stage 2, the patient is symptomatic. They will have a mild to moderate loss of vision, but without any irritation, pain, photophobia. But the patients can have moderate to severe corneal guttae and mild corneal edema, and the visual acuity can be affected 20/20 to 20/80. And stage 3 and stage 4 are severe grade Fuchs endothelial dystrophy, and here you can see confluent corneal guttae, moderate to severe corneal edema, epithelial bullae, and moderate to severe vision loss. And stage 4 is a stage of scarring, subepithelial scar or fewer epithelial bullae in the periphery, and you can even see a panstromal scar in these cases. So the grading is important, and then you can decide about the type of surgery you want to go ahead when you are combining with the phacoemulsification. So this is a case of stage 1. Actually, you can see there is amount of edema. It's between stage 1 and stage 2. The patient is slightly symptomatic, and when you are doing phaco alone, you have to take certain measures, and it's ideally you should do a sclerocorneal tunnel, because the peripheral cornea is almost normal. You don't want to disturb the peripheral cornea, which is normal. Create a central rexis, and do phaco emulsification in the back. And this is actually I'm doing a chopping technique, direct chopping technique, and let's you divide the nucleus into multiple fragments. So you make it 7 to 8 segments, and try to emulsify it, and gently you do, and replace the antechamber with the viscoelastic substance or high molecular weight viscoelastic substance on and off. Don't allow the chamber to collapse. uh, and then go ahead and aspirate the cortex, and see to it that your the irrigation port is not directed towards the corneal endothelium. It should be sideways or on the iris plane. Inject the lens and place the lens inside the bag. Remove all the viscoelastic substance during the IA, and go behind the IOL. Remove all the viscoelastic substance, and any post-operative rise of IOP has to be avoided, and don't tighten the chamber too much, and any rise of IOP post-operatively also can cause damage to the endothelium. This is how it is pre-op and post-op. There is change in the endothelial cell count, but usually these patients can manage for at least 3 4 years. But cases like this, you have a significant edema, the patient is symptomatic, and the visual acuity is affected, and your specular microscopy picture shows this picture. No cells could be detected, mainly because of the corneal edema. So you have to combine it with either phaco with DSEC or DMEC. I prefer DSEC. For the simple reason that I don't have excess tissue. I buy tissues from eye banks, so I don't want to experiment on that. My DSEC, I never waste any tissue. DMEC, there is a possibility I lose that tissue. So Descemetorrhexis, stripping of descemetes has to be done in these cases because the endothelium is thick. The endothelial descemetes complex is thick here because of the abnormal collagen deposition. And some cases like chronic PBK, I usually don't do a descemetorrhexis in those cases. But in this case, I do it. See to it that it is not extending to the periphery. Sometimes your graft the area there will be clear cornea, but the periphery you have bullae that it will be disturbing for the patient. So see to it that it doesn't extend to the periphery. And I use a sheets glide for all the cases. It actually, we can even in the collapsed globe you can use this technique. And this is the post-operative first day and 6 weeks post-operative picture, and the anti-segment OCT picture of the same patient. So you can even go further down and use a thin graft. You can go up to 400, 450 microns and prepare a thin graft lenticule. And of course, the handling of these thin grafts is similar to handling of PDEC graft. Not as difficult as DMEC graft. I usually stain these thin lenticules so that identifying these tissue in the antechamber will become easy. Yeah, this is a thin graft, thin lenticule you can see here on day 1. So it's the results are as good as DMEC or PDEC in these cases. So we have to identify the stage of Fuchs, and if it is a stage 1 and the patient has cataract, you can go ahead and do a phaco with the viscoat. If it is stage 2 and stage 3, you can do phaco with the DSEC or DMEC. And my preferred technique is DSEC. We have a talk on DMEC by Dr. Siddharth, the next talk. And if there is a subepithelial scar or if there is a panretinal scar, a pancorneal scar, then you have to either plan to do a phaco with the DSEC, DMEC or PK. If it is a dense scar, you have to do a PK in these cases. Thank you very much.